we'll be performing a shoulder physical exam. We've already assumed that you've taken a history, realizing that the history will dictate 80 to 90% of your diagnoses, but we will do a complete physical exam. I'm going to do all maneuvers here, knowing that in a focus exam you may not do all complete maneuvers, but it's worth describing that. So our musculoskeletal exam is comprised of multiple parts, but it should be done in this order. It should always be done with inspection, palpation, range of motion, strength testing, and special test, and so we will do that in this order. So inspection, you want to get an idea of the muscle symmetry, looking for any scars, looking for any skin changes, or looking for any atrophy. You want to do that from the front and the back, and note if there's any asymmetry, and then have an explanation of why there are any skin changes or any difference there. And again, noted any scars. That would be our inspection portion of the exam. Next, we would move to palpation. It is a purposeful palpation, looking for specific structures. For the shoulder, our purposeful palpation would be palpating both sternoclavicular joints to see if there's tenderness there, marching along the clavicles out to the acromioclavicular joints with palpation there, and then looking for the long head of the biceps inside the bicep groove to see if there's tenderness there. You can, in addition, try to palpate for the major muscle groups to see if there's tender points, specifically in the trapezius muscles or in the deltoid muscles. But the majority of the palpation for the shoulder is, again, the sternoclavicular joint, the acromioclavicular joint, and the bicep tendon. If you're having trouble locating the long head of the bicep tendon in the groove, you can put their arm in neutral and you can internally and externally rotate their shoulder, and you should feel a structure that falls underneath their finger, and that is the long head of the bicep, and you're looking for tenderness there. We've completed inspection, we've completed palpation. Next we'll move to the range of motion. Range of motion should be done actively, meaning the patient does the work. If there is restricted range of motion, you can try doing passive where the clinician does the movement. Be very mindful of not doing that in acute trauma because you do not want to aggravate an injury such as a fracture. So we will do active range of motion. The first movement we will do is forward flexion. You can demonstrate that to the patient. So bring your arms in front of you as high as you can. You're going to ask them to slowly or controllably lower their arms down to the starting position. That's actually a good test for their muscle strength too. That was forward flexion. Next we will do abduction, and abduction is with the arms to the side all the way over the head. Excellent. Go ahead and bring that back down again. And he shows good control. Someone who had a complete rotator cuff tear would be unlikely that they can control their arms coming down into the neutral position. When you are doing that abduction, you also want to look for something called scapular dyskinesis. If I could have you flip around, please. And so scapular dyskinesis is when the scapula do not move in concert with the glenohumeral joint. And so for every 2 degrees of the glenohumeral joint, the scapula should move 1 degree. So it's really 2 to 1, and they should come down in concert. And so the way to test that is go ahead and do full abduction for me again, and go ahead and lower your arms down. And you can see his scapula moving in concert. Do that one more time, and bring that back down. Excellent. And so it will be obvious when the scapula are not working in concert, and that would be called scapular dyskinesis. You can come back down here for me, please. So we've done forward flexion, we've done abduction. Now we're going to do adduction, adduction, where you cross your arm. Excellent. And go ahead and do that on the other side. This is also a test for the AC joint because we're compressing the AC joint in that time. So forward flexion, abduction, adduction. Next, we're going to do internal and external rotation. There's multiple ways to do this, and we'll demonstrate all of those. With your arm in neutral, this would be external rotation. Go ahead and do that for me. You would also ask the patient to hold that for a count, and this tests the integrity of the rotator cuff muscles if they could hold external rotation. Now go ahead and bring that all the way in. That's internal rotation. The other way to do external internal rotation is with your arms at neutral. You would go ahead and bring your hands up. That is full external rotation. And go ahead and bring them all the way down. And that's internal rotation. Go ahead and bring your arms back to neutral. And then there's a functional test. Let me have you flip over one more time, where you would ask the patient to scratch their back underneath. And this is a functional internal rotation movement, and you could gauge what level, spinous process level, they can get their hand to. And this would be important for rehabilitation. And this would be full internal rotation as a functional movement. Do your other hand, please. And those, again, are normal on there, too. So just to revisit, come back again for me. With him in neutral, this would be external rotation. This would be internal rotation. With your hand here, show me external rotation, internal rotation, and then go ahead and demonstrate the scratching your back. Perfect. And so those are tested internal, external rotation. So now we've done our inspection, we've done our palpation, we've done our range of motion. Now we're going to go ahead and do strength testing. We're looking specifically for rotator cuff muscles. The first we'll do is the supraspinatus muscle, which is responsible for abduction. Knowing that when we test abduction, that we actually have the deltoid contributing, so it's pretty hard to isolate it. But the way we do that is we do what's called the empty can test. And if you can imagine you had a soda can and he was dumping the soda can out, that's what the empty can test is. Notice he's put his arms in the plane of the scapula. He does not have that over here because the plane of the scapula is about 30 degrees. And so what I would ask him to do is resist me, even if it hurts. And I would apply a fair amount of force on there. Some would argue that you would try to break the muscle strength. I would argue that you need to do enough to know that the muscle has integrity and he's strong, and it's not a contest to see who's stronger on there. Again, you have a large patient and you may be smaller. It's going to take a lot more force. Likewise, if I had a big linebacker, it would take me a lot more force to do that too. So again, we're testing the integrity of the supraspinatus muscle and seeing if he has any pain or discomfort with that. You can bring your arms back down. It's important to talk about grading muscle strength when we're doing musculoskeletal testing. The muscle strength grading is 0 to 5, with a 5 being full strength, the 0 being no activity whatsoever. So again, this was our supraspinatus. And now go ahead and bring your arms down. The next we're going to do is infraspinatus and the teres minor, which are responsible for external rotation. And so you can test both at the same time with the elbows fixed. You ask them to bring their arms out. You can see that he's actually trying to move his elbows here, and so the way to actually test that, you would do that at a single arm at a time. You would fix their arm to the side, and you would have them push out against you, and then you would compare the two. So again, supraspinatus muscle, infraspinatus muscle, and teres minor muscle. Next, we have to test the subscapularis, which is an internal rotator. And so one way to do that is to ask them to bring their hands towards their belly. Okay, but realize you have other muscles such as your pec that would contribute to that. And so a variation of that test is what we call the lift-off test. Let me have you flip around. And so you would ask the patient to put their hand in the small of their back, keep their hand a little bit off their back, and say, resist me as I push your hand to your back. That is testing the subscapularis muscle. I will tell you, somebody that has rotator cuff dysfunction, this can be a painful procedure, but this is what we would call the lift-off test for testing the subscapularis. Okay, go on back, please. So again, we've done inspection, we've done our palpation, sternoclavicular, acromioclavicular, bicep tendon. We've done our range of motion where we did forward flexion, we did abduction, we did external rotation, and you'll show those for me. And then we went ahead and we did our muscle testing where we tested the supraspinatus muscle. Then we tested the infraspinatus muscle and the teres minor, and then we went ahead and did the lift-off test for the subscapularis. So next is our special test. Our special test we'll be looking for specifically for impingement signs, and so one is the Hawkins test. To do the Hawkins test, you actually bring the arm at 90 degrees of flexion and the elbow at 90 degrees, and then you ask the patient to relax. This is a pure passive movement, so the arm should fall in your hand, and then with your right arm supporting the elbow, you would try to internally rotate the shoulder and see if there's a compression or if there is dysfunction of the rotator cuff muscle. The patient would have pain with this movement. That is your Hawkins test. The next test is called the Nears test, where you bring the arm in front of the body, you maximally internally rotate, and you elevate the arm to see if there's discomfort. A patient with impingement sign at about 90 degrees, they will have some discomfort with lifting the arm up. This is the Nears test. This is the Hawkins test. Those are your impingement tests. Then the next test we're going to do is looking for tenderness at the bicep tendon. This is called a Speeds test, where they fully extend the arm and the shoulder is at a position of about 50 to 60 degrees, and you ask them to elevate their arm to the ceiling, and you're looking for discomfort up in here or down in here for the bicep tendon. So this is a bicep test called the Speeds test. Next, we're going to test the AC joint. All our AC joint tests is compressing the AC joint. If that causes pain in and of itself, that's a positive AC compression test. You can aggravate that or exacerbate that by asking the patient to lift their elbow up to the ceiling, and again, that will compress that AC joint. And you would do that on the other side as well if you were testing that. And so then we're going to go ahead and look for some labral test. And our labral test would be the active compression test, where the shoulder is flexed to 90 degrees. You maximally internally rotate. You ask the patient to lift their arm up to the ceiling. If that causes discomfort, then you go ahead and maximally externally rotate. Ask and repeat that maneuver. And if the patient has less discomfort, that can be indicative of a labral test. So again, active compression test is flexed to 90 degrees, arm in front, lift your arm up to the ceiling, then externally rotate, lift the arm up to the ceiling, and you're looking for decreased discomfort. The last labral test I want to show you is the bicep load 2 test, where you're holding the wrist and you ask the patient to make a bicep curl, knowing that the long head of the bicep is attached to the superior portion of the labrum, and if it's pulling there, that can be indicative of some labral pathology. So we've done our impingement test, the Hawkins test, the Neers test. We did the Speeds test for the bicep. We've done our AC compression test. And then we have done our active compression test. And then we did our bicep load test. Finally, we're going to look for instability of the shoulder, and the way we do that is we reproduce the movement that would cause an anterior displacement of the shoulder. And what we do is with the shoulder at 90 degrees, we maximally externally rotate and see if the patient has a sensation that their shoulder wants to dislocate or if it causes pain. If you can maximally externally rotate and they cause no discomfort, then that's not any anterior instability. If they have discomfort, then we're going to do one final test called the relocation test. So the apprehension test, it causes them discomfort. I would ask him to lay down. They need to scoot all the way over towards me so that the shoulder is actually off the table, so that the shoulder is not being stabilized by the table. I would go ahead and reproduce that instability or the apprehension test. As soon as they have pain, then I am pushing down on the humeral head, trying to relocate the humeral head. If the patient says that does not hurt them now, that is a positive relocation test, and you actually can get a little bit more of external rotation. If that causes less pain, so again, a positive relocation test, when you go to let go of this, you must actually bring the arm back so that you're not popping that humeral head out. So again, that was the relocation test, and you can bring the patient back up. And that would complete our physical exam for the shoulder.